The weakness gets worse on repetitive nerve stimulation test. Then the diagnosis is most likely myasthenia gravis. Serum anti-acetylcholine receptor antibodies will be positive. And Androphonium stimulation test, which is also known as tensilon test. The fatigue or muscle weakness will improve on tensilon test or Androphonium stimulation test. Androphonium is basically a short-acting acetylcholine esterase inhibitor. Acetylcholine esterase is an enzyme which leads to the breakdown of acetylcholine. So if we give an acetylcholine esterase inhibitor such as Androphonium, it will lead to the buildup of acetylcholine in the synapses, which will improve the muscle weakness or fatigue. So there are two tests which can confirm our diagnosis. One is repetitive nerve stimulation test, and the other one is Androphonium stimulation test. The muscle weakness will get worse on repetitive nerve stimulation test due to depletion of acetylcholine reserve, and Androphonium stimulation test will improve the weakness because of increased level of acetylcholine in the synapses. The management is acetylcholinesterase inhibitors such as long-acting acetylcholinesterase inhibitors such as pyridostigmine, and as it is an autoimmune disease, so immunosuppression can also help in controlling the symptoms of the disease. Immunosuppression can be obtained either by you prescribing corticosteroids or azathioprine, and if there's thymoma, even if there's no thymoma, thymectomy or the removal of thymus gland is also beneficial in the treatment of myasthenia gravis, because the antibodies that are produced against the acetylcholine receptors, they are produced in the thymus. So removal of thymus can also help in the treatment of myasthenia gravis. So this was all about myasthenia gravis. The second condition, along with Guillain-Barré syndrome, the differences between these two is that in Guillain-Barré syndrome, there will be history of respiratory tract infection or gastroenteritis, while in myasthenia gravis, there will be no such history. And an important differentiating point was that in myasthenia gravis, the weakness gets worse with exercise, or the weakness is worse in the evening. Is there any question anyone want to ask?
So if the patient's the initial management is given as pyridostigmine and immunosuppression, and if they are improved, then we don't do thymomectomy, or it is should be done along with it.
If the patient condition improved with these two
First line medications.
yes, then thymomectomy may not be required, because thymomectomy is a surgical procedure, and it's not always easy for patients to undergo surgery.
Okay.
Patients usually try to avoid surgery.
Right. But if it is not improved, then the last resort is thymomectomy.
Yes, yes.
Thank you.
Any more questions? So what will happen to the reflexes in Guillain-Barré syndrome? Can anyone tell me?
They'll be reduced.
And what will happen to them in myasthenia gravis?
They'll be normal. Deep tendon reflexes will be normal.
Yes, the reflexes will be normal in myasthenia gravis. Now, if someone present to you with this sign and symptom of myasthenia gravis, but his reflexes are exaggerated, or there is hyperreflexia, or the reflexes are increased, then what will be your diagnosis? Which condition has a increase in the reflexes? So remember that if the symptoms of muscle weakness and there is increased reflexes or hyperreflexia, then the diagnosis will be motor neuron disease. Motor neuron disease is a disease in which upper motor neurons and lower motor neurons both are affected, and only the motor system is affected. So a patient motor neuron disease is also an autoimmune disease that we will discuss in the coming slides. And just remember the difference that muscle weakness with increased reflexes is motor neuron disease. Muscle weakness with decreased reflexes is Guillain-Barré syndrome. Muscle weakness with normal reflexes is myasthenia gravis. Now, another condition, the fourth condition in which there is muscle weakness plus reflexes absent initially, but they can be elicited after exercise or after repetitive nerve stimulation. So we have four conditions at our hand. One is muscle weakness with reduced reflexes, which is that one?
Guillain-Barré.
Yes. Now I want someone else to answer. Muscle weakness with increased reflexes. Who will answer this one other than Dr. Musarat?
Motor neuron disease.
Motor neuron disease. Now, muscle weakness with normal reflexes. Dr. Shafraz.
Is that myasthenia gravis?
Yes, myasthenia gravis. Now, the fourth condition, muscle weakness with reflexes are initially absent, but they can be elicited by after exercise or after repetitive nerve stimulation, and that condition is Lambert-Eaton syndrome. Lambert-Eaton syndrome. Lambert-Eaton syndrome. The presentation of Lambert-Eaton syndrome is similar to myasthenia gravis. Uh, in myasthenia gravis, antibodies are formed against the acetylcholine receptors, while in Lambert-Eaton syndrome, as I told you before, there is a presynaptic nerve terminal, and from presynaptic nerve terminal, acetylcholine is released. On presynaptic nerve terminals, there are voltage gated calcium channels. On presynaptic nerve terminals, there are voltage gated calcium channels through which calcium enters inside the nerve terminal, and when calcium enter inside the nerve terminal, it leads to the release of acetylcholine. So the function of these voltage gated calcium channels that are present in the presynaptic nerve terminal is that it is associated with the release of acetylcholine. Now, in Lambert-Eaton syndrome, antibodies are formed against these voltage-gated calcium channels. So this point is important to remember that The basic normality in Lambert syndrome is the formation of antibodies against voltage-gated calcium channels. So when voltage-gated calcium channels are destroyed, then acetylcholine is not released from the nerve terminals, and which can lead to muscle weaknesses, etc. Now, what happens after repetitive nerve stimulation or after exercise? After exercise or repetitive nerve stimulation, the amount of calcium in the synaptic nerve terminal increases. That's why after repetitive nerve stimulation or after exercise, the strength or the power of the muscles improves in Lambert-Eaton syndrome. And that's why reflexes can be elicited after repetitive nerve stimulation or after exercise in Lambert-Eaton syndrome, because the abnormality in Lambert-Eaton syndrome is decreased level of calcium in the presynaptic nerve terminals. But after repetitive nerve stimulation or after exercise, the amount of calcium increases in the presynaptic terminal, which leads to improvement in the power of muscle contraction, or deep tendon reflexes can also be elicited after repetitive nerve stimulation. Remember that Lambert-Eaton syndrome is associated with small cell lung cancer. An important disease that is associated with Lambert-Eaton syndrome is small cell lung cancer. So Lambert-Eaton syndrome is also known as myasthenic syndrome. So myasthenia gravis and myasthenic syndrome. In myasthenia gravis, antibodies are formed against acetylcholine receptors, and in Lambert-Eaton or myasthenic syndrome, antibodies are formed against presynaptic calcium channels. Weakness, proximal muscle weakness. Remember that in myasthenia gravis, these symptoms are more common, such as drooping of eyelid, dysphagia, dysphonia, and dysarthria, while in myasthenic syndrome, proximal muscle weakness is more common than these symptoms. How in the Plab 1 exam, the proximal muscle weakness will be described. Inability to stand from a seated position, inability to climb stairs. This is how proximal muscle weakness will be described in Plab 1 exam scenarios. Investigation will be CT scan or MRI of the chest. Why CT scan of MRI? CT scan or MRI of the chest in case of Lambert-Eaton syndrome, because Lambert-Eaton syndrome is small cell lung cancer. Other tests that can be used to confirm the diagnosis is repetitive nerve stimulation test, which will improve strength momentarily. And another investigation is antibodies against voltage-gated calcium channels will be present in the serum of the patient with Lambert-Eaton syndrome. Management is simple. We need to treat the underlying neoplasm, or diaminopyridine can also be used. Diaminopyridine is a drug which leads to increased calcium levels in the presynaptic terminal. So it can be used in the treatment of Lambert-Eaton syndrome. So these were,
What will happen?
yeah,
Sorry. What will happen to the reflexes? Are they going to be reduced, or there won't be any reflexes at all in
initially
Lambert?
Lambert-Eaton syndrome, there are reflexes are absent.
Right.
They will be absent initially, but they can be elicited after repetitive nerve stimulation test.
Okay.
Absent initially, but present after repetitive nerve stimulation test.
Okay.
Any more questions? So the fourth condition with the muscle weakness and increased reflexes is motor neuron disease, and the most common cause of motor neuron disease. This is called motor neuron disease because in this disease or the condition, the motor neurons are affected only, and nothing happened to the sensory neurons or other neurons. So that's why it is called motor neuron disease. And the most common cause of motor neuron disease is ALS. Amyotopic lateral sclerosis is the most common cause of motor neuron disease. There will be weakness, limb weakness, dysphagia, slurring of speech. So the presentation of all these four conditions can be similar. The only differences is in the examination and in the investigation and in the history of the patient. So patient with weakness, dysphagia, foot drop, fasciculation, etc., and increased reflexes, the diagnosis will be amyotropic lateral sclerosis or motor neuron disease. In motor neuron disease, autoimmune panel will be normal, while in myasthenia gravis, autoimmune panel will be positive, such as antibodies against acetylcholine receptors will be positive in motor neuron disease, while antibodies against voltage-gated calcium channel will be positive in myasthenic syndrome or Lamberton syndrome. Now, another condition of spinal cord is syringomyelia. What is syringomyelia? Syringomyelia is basically syringo mean formation of syrinx or cyst or cystic cavity. Syringo mean formation of cystic cavity. Mylia means spinal cord. So a cystic cavity is formed in the spinal cord. It is formed centrally and then it expands out laterally. It is formed medially and then it expands out laterally. And the first pathway that is affected by the syringomyelia is spinothalamic tract. What will happen if spinothalamic tract is damaged due to formation of a cystic cavity? What is the function of spinothalamic tract? Can anyone tell me? What is the function of spinothalamic tract? Anyone?
Parasympathetic activity.
Spinothalamic tract.
Sympathomimetic activity. Free.
Sympathomamic tract is
Sorry, just confusing myself.
Temperature.
Dr. Joe, what are you saying?
It's responsible for temperature, I think.
Yes, pain and temperature sensation. Dr. Shafraz, do you agree with Dr. Joe?
Yes, I do.
So, yes, so the function of spinothalamic tract is to carry pain and temperature sensation. While Fine touch and position and vibration sensation is carried by dorsal column tract. Dr. Prasad, you did not attended that lecture in which we discussed the function of different tracts. That's why you didn't have idea.
Yeah.
So the function of spinothalamic tract is to carry pain and temperature sensation. So remember this now.
Yeah.
So the first pathway, so there's a formation of a cystic cavity in the spinal cord.
So the
That
fine and touch vibration sensation is
denoted by dorsal
the
column tract.
dorsal column.
Dorsal column medial lemniscal system.
Okay. That's
So the first pathway that is affected by the Syringomyelia is spinothalamic tract. So the patient will present to you with loss of pain and temperature sensation. The typical scenario that is usually asked in the Plab 1 exam, that the patient will burn his hand on a candle fire or candle light, and he will not feel any pain. So the patient presentation will be a painless burn, because there is a loss of pain and temperature sensation, usually in the upper limbs first and then in the lower limbs. So the patient will present to you with a painless burn. He will not feel any pain while burning from a fire. So that's how a patient of syringomyelia will present to you. Other signs and symptoms can also manifest when other tracts are affected. Remember that spinothalamic tract crosses to the opposite side in the spinal cord. So there will be pain and temperature loss in the contralateral side of the body. If syrinx or syringomyelia is on the right side, then there will be pain and temperature sensation loss of the left side. But if both of the tracts or the tracts of both sides are affected, then there will be loss of pain and temperature sensation in both the limbs, which is the usual presentation in case of syringomyelia. So neuropathic pain in the upper limb exacerbated by exertion or coughing. Spinothalamic tract involvement will lead to loss of pain and temperature sensation, which may lead to painless upper limb burns, which is the usual presentation. And if corticospinal tract is affected, remember the function of corticospinal tract is to control the muscle movement. So there will be muscle weakness if corticospinal tract is involved. If dorsal column tract is involved, then there will be loss of light touch, vibration, and position sensation as well. Now, if this cystic cavity extends into the brainstem, how you will know that cystic cavity has extended into the brainstem? You will know it if there is any cranial nerve involvement or signs of cranial nerve involvement, such as facial palsy. Facial palsy will result from the involvement of cranial nerve 7 or facial nerve. Similarly, other cranial nerves can be involved. So if cranial nerves are involved along with loss of pain and temperature sensation, then it will be known as syringomyelia. Syringomyelia, if cystic cavity is present in the spinal cord. Syringomyelia, if the cystic cavity extends into the brainstem, which we can identify if signs of cranial nerve damage are present. So motor system, sensory system, and reflexes all can become infected, but the first of the tract that is affected, or the most common tract that is affected, is spinothalamic tract. So the patient will present to you with a painless burn of the upper limbs. The treatment is mainly surgical. Surgical drainage of the cystic cavity will result in the improvement of the symptoms. Amyotopic lateral sclerosis, we have already discussed that it is the most common cause of motor neuron disease, and the motor neuron disease will present as muscle weakness plus increased reflexes. Remember that amyotopic lateral sclerosis has both signs of lower motor neuron lesion and upper motor neuron sign, upper motor neuron signs such as increased reflexes and lower motor neuron signs such as fasciculations. Both of them are present. The treatment for amyotropic lateral sclerosis is a neuroprotective drug. Riluzole can be used in the treatment of amyotropic lateral sclerosis. Non-invasive positive pressure ventilation can also be used if there is involvement of respiratory muscle, and nutritional support as if the patient is having dysphagia, then we need to give nutritional support as well. So an example, a 56-year-old presents with a bilateral progressive weakness of his arms, SOB while doing up the stairs, hoarseness, difficulty swallowing liquids. So there's hoarseness of voice, hoarseness of voice. If there's hoarseness of voice, then which cranial nerve is involved? Can anyone tell me? Which cranial nerve sign?
Recurrent laryngeal.
Glossopharyngeal.
Recurrent laryngeal nerve is which cranial nerve? 9, 10, 11, 12, 13. Yes. Cranial nerve 10 involvement will leads to hoarseness of voice, difficulty in swallowing. Which cranial nerve is involved?
Glossopharyngeal.
Cranial nerve 9. Excellent. Glossopharyngeal nerve supply the muscle of the pharynx. So if there is lesion of cranial nerve 9 or glossopharyngeal nerve, there will be difficulty in swallowing. Atrophy and weakness of the muscles of trunk. So there is atrophy of the muscle of the trunk, back and neck, and tongue. And deep tendon reflexes are positive for upper motor signs. Autoimmune. So increased reflexes or exaggerated reflexes or deep tendon reflexes positive for upper motor neuron sign means it's a motor neuron disease or amyotropic lateral sclerosis. Remember that amyotropic lateral sclerosis is the most common cause of motor neuron disease, so we can use both of these terms interchangeably. There are some other diseases which can cause motor neuron diseases, but they are very rare causes of motor neuron diseases. Motor neuron disease can be caused by progressive bulbar palsy, progressive muscular atrophy. About 80% or 90% of the cases are due to amyotropic lateral sclerosis. 2% are due to progressive bulbar palsy. So you only need to remember amyotropic lateral sclerosis as the cause of motor neuron disease. Now another important condition for Plab 1 is multiple sclerosis. Remember that multiple sclerosis, as in Guillain-Barré syndrome, there was demyelination of the peripheral nerves. While in multiple sclerosis, there is autoimmune demyelination of nerves which are present in the central nervous system, such as brain and spinal cord. So what are the manifestations of multiple sclerosis? Remember that any part of the central nervous system can be affected in multiple sclerosis, starting from the cerebral cortex brainstem, cerebellum, spinal cord, any part of the central nervous system can be affected in multiple sclerosis. How you are going to diagnose multiple sclerosis? Remember that the most important point or clincher in favor of multiple sclerosis is that it has a relapsing and a remitting pattern. What is relapsing and remitting pattern, which is present in almost 90% of the cases? Relapsing and remitting pattern is that the patient will have signs and symptoms for 1 or 2 months and followed by a period of complete remission or complete recovery. So the usual presentation in Plab 1 exam will be a patient with visual problems. Remember that optic neuritis is the most common presenting feature of multiple sclerosis. So optic neuritis or visual problems will be a part of every clinical exam question. Along with optic neuritis, there will be other neurological signs, and those neurological signs can be sensory, they can be cerebellar signs, they can be cerebral signs, they can be signs of spinal cord involvement. So any signs can be present. If there is involvement of cerebellum, the patient will present with ataxia, tremor, dysarthria, nystagmus, dysdiadochokinesia. If there is involvement of brainstem, there will be the patient will have signs and symptoms of cranial nerve involvement, such as diplopia, gaze palsy, facial numbness, ataxia, etc. If spinal cord involvement, then multiple sclerosis can cause a transverse myelitis. Again, we all know that ascending and descending tracts are present in the spinal cord. So if corticospinal tract is affected, there will be, if it is affected at the level of cervical spinal cord, then there will be quadriparesis. And if it's involved in the lumbar region, then there will be paraphresis. And also there will be urinary retention. And tone and reflexes will be brisk. So it can involve spinal cord, which will lead to transverse myelitis. It can involve brainstem, which will result in brainstem involvement sign and symptoms. It can involve cerebellum, which will result in cerebellar signs. The most important thing to remember is that the common presentation will be optic neuritis. How optic neuritis will be described in the Plab 1 exam? The patient will have blurring of vision, or the optic disc will be swollen or pale. So a patient with a blurring of vision and or swollen or pale optic disc plus other neurological signs, which has a relapsing and remitting pattern, then you will suspect multiple sclerosis. So what are the three important points for the diagnosis of multiple sclerosis? Relapsing and remitting pattern, optic neuritis, which will be described as swollen or pale optic disc or blurring of vision, plus other neurological signs. Relapsing and remitting pattern, optic neuritis, plus other neurological signs. Other neurological signs can be of transverse myelitis, can be of cerebellar lesion, can be of brainstem lesion. Any part of the CNS can be involved. What is the treatment of multiple sclerosis? As it is an autoimmune condition, so immunosuppressant or drugs or anti-inflammatory drugs can be used in the treatment of multiple sclerosis. In acute cases, the drug of choice is oral or IV methylprednisolone, which are steroids, and steroids are a very good anti-inflammatory drugs. So in acute cases, steroids are used for the management of multiple sclerosis, and in long term or for chronic use, uh, glatiramer acetate, which is also an anti-inflammatory drug, or interferon beta can be used in the treatment of multiple sclerosis. Is it clear to everyone? Does anyone want to ask any question? Interferon beta and glatiramer are used for the long-term treatment of, or they are first line for the long-term treatment of multiple sclerosis. Monoclonal antibody such as natalizumab can also be used as a second-line drug in the management of multiple sclerosis. Is it clear, everyone, up to this point? No question? There's a question. Clear. Okay, it's not a question. Okay, guys, then we'll end our session here today. We were not able to finish the neurology today. We'll finish it tomorrow. Only few topics are remaining, and we will also discuss the important drugs which are used in neurology, their side effects, so that while doing pharmacology, you would already had covered drugs that are a part of management in the neurological diseases. So I'll see you guys tomorrow. Until then, it's a goodbye from my side. Take care, Allah Hafiz, and good night.